Let me start the next, continue this discussion of spending trends by focusing briefly on specialty drugs. And the question is, what role does growth in specialty drug spending have in your forecast of overall spending? And what percent of the overall spending gains now are coming from growing spending for specialty drugs?
So it's like, what was it, 27% of the total, about close to $500 billion in pharmaceutical spend was specialty in 2015. It's probably somewhere in the low 30s now. The rate of increase, though, the specialty drug trend increase is running in the high teens to over 20%, I think, whereas the traditional drugs are running in the low single digits. So the expectation is, I think, by 2020, close to half of total prescription drug spend will be specialty spend. And I mean, then we can keep going into, but Paul is a whole set of questions, but that's where I think managed care and their pharmacy benefits management business relative to a standalone PBM that does not have a medical insurance underwriting business model and ultimately does not have provider networks. They do not have specialist networks, and they do not have health system networks where these drugs are administered. They might have a smattering of infusion clinics. I think CVS has 73 infusion clinics, but they cannot influence utilization of drugs that are administered in an injectable or an infused setting. And that is going to become the largest part of the prescription drug market. So up until now, we've had, managed care is this huge cost pool, for every 100% of $100 of spend. If in the old days only 10 to 15 was pharmaceutical and growing at a very low single-digit increase, because the generics cabinet had taken over and the innovation S-curve was weak. They paid attention to the hospitals, and my God, they've really handed the hospitals a very difficult deal. But now they are looking at it and saying, gee, now we've got to do something on the pharmaceutical side. And where is this increase? It's in specialty. That's where some of these strategies we'll talk about. I don't want to deliver a monologue here, but will start to become apparent.
So later on I'll ask you about, because I think you were implying that there is a strong reason now, as far as management reason, for the PBMs to become much more closely aligned with the insurers than they've historically been.
Just one point to add on to that, which is that one reason maybe that we have room for specialty pharma trend to be as high as it is it until recently hasn't been that large a percentage of the total, but also because everything else has been so moderate. And so specialty pharma is really the one thing in particular that is increasing, but it's happening in the context of overall slow trend, and therefore hasn't been treated as much as sort of a crisis as it might otherwise be.
So let me just make an observation. So the flip side of this is a couple of things that have happened that may impact trend going forward. And that is, one, you have uncovered or discovered, and for the publicly traded specialty pharmaceutical companies have eliminated most of the opportunity to reprice old drugs at outrageous rates. So even though that might have been a very small part, it was nevertheless a very troublesome, annoying part of setting up these specialty pharmacy networks that would then get people onto these drugs and try to negotiate a way for the health plans to cover it, super pricing a lot of these drugs. So if you look at the stocks of Valiant, of Horizon, of some of the other companies that have been doing these sorts of things, of buying up drugs and then making money just simply by slapping a new price on that game's done. So at least you're getting some mitigation of that small amount of the gaming of the system and the pressure that it's putting on the pharmacy trend. The second point that I'll make is that I think that it's already, the horse being already out of the gate. That some of the contract wins from OptumRx were precisely because they were able to do this integration, what they call the synchronization of the health event as well as the pharmacy event, and the data around it, and as well as the management of the patient around those two events and the data. So it doesn't matter if it was a scene at a physician office or at a hospital or whatever, that what you're no longer doing, and again, this is very similar to what the health insurance companies did in medical care. You're not just trying to price the treatment, you're trying to price the episode of care efficiently. So what does that mean? That means you're looking at the patient in totality. Sound like patient-centered medicine? Look at the patient in totality and see what services need to be delivered, where they need to be delivered, and what is the appropriate price to pay for that. In some cases, it's going to mean give more up front. In some cases, it's going to mean when you're discharged from the hospital, you're going to get a call if you don't fill your post-discharge script within 24 hours. Why didn't you do it? Your doctor wants you to do that. He wants you to be healthy. How can we help you get the script filled? So there's going to be some increases as healthcare, as the approach to managing healthcare changes. There's going to be some increases in spend in some area, and there's going to be greater scrutiny and decline in others. And the final thing that I'll mention is, some of these drugs that were repriced or that had relatively high prices were generics. Sort of this notion of a branded generic, which is kind of interesting. And they were able to have some pretty good periods of exclusivity, monopoly driving price higher. So one hopes that with an FDA leadership that is more focused on expediting approvals of lower cost generics, that competition will begin to abate some of the price pressure as opposed to the unit growth pressure, but the price pressure. And then the final thing is that, as we're not talking specifically about things like Sovaldi or some of the other sort of, just completely innovative drugs that actually are cures, even though they're high price spends on the drug. A, they've moderated substantially as more drugs in that class come on, and B, they actually cure patients. So part of what we're paying for in the specialty drug area may be oncology drugs that actually offer, if not a cure, then substantially a cure, such a great improvement in quality of life for a longer period of time that they are in some cases justified as either financially worth it or socially worth it. And so there's a lot of inputs into this pharmacy cost trend issue that are sticky, that are complicated, and some are going to help it to abate and others are going to cause it to increase. But it has got to be, and I couldn't agree with Anna more, it has to be integrated into the view of the patient as a whole, meaning the medical underwriting as well as the pharmacy underwriting has to be integrated.
If I could make just one point there on, not to get into a debate on Optum, but
we have before.
Yes, Optum RX, their account wins have mostly been the type of sort of carve-out pharmacy PBM accounts. So those are some very prestigious ones that they have won. I guess the point I'm making is it isn't clear that large employer purchasers have necessarily yet embraced the model of, okay, we want everything in one basket, where we want one carrier to be managing both the medical and the pharmacy side. Now that could very much be where we're going. It makes sense that elements of that are where we're going. But I don't think we've seen the evidence yet that that's resonating in the marketplace yet.
Yeah.
Well,
So
I think there have been four accounts, right? It was GE, CalPERS, and these are all thought-leading
Texas.
accounts. Texas
Sure.
Retirement System and State of New Jersey. I think there's a difference between fully insured versus self-insured, because when you're talking about a fully insured employer account, they're going to want to go with one provider because they can see the immediate impact on their medical costs versus what it would be if they had a separate pharmacy benefits manager that's doing the pharmacy benefits management. So there's more likelihood that they'll go with a captive, so-called Optum RX-like pharmacy benefits manager under an insurance umbrella. I'll make one more point, though, on Matt's assertion about have large employers embrace this. We still have, and it feels to me that they have diminishing power as We've had more consolidation, in the health insurance industry, but we still have the Aon Hewitts, of the world, who are benefits consultants. And as the Uniteds of the world get more power and Optum and United become a one-stop shop for the employers, their role is getting increasingly marginalized. And so I do think there's some last vestiges of that we're seeing in the self-insured market still. Because, when we were at Aetna, they were I was at Aetna, they were extremely powerful. This was like 12 years ago, 12, 15 years ago. And they used to, prevent they would want to do a standalone pharmacy and a standalone dental, and just because then they became the aggregator of everything. And today you have a far more consolidated industry, and an industry that's evolved their business model to do all of that well. I've also heard from investors who are long, the CVS's and the Express Scripts of the world, how this whole Optum thing is smoke and mirrors, because all ultimately they're doing is underpricing relative to CVS. Who cares? I mean, at the end, if they're underpricing and they can still keep the same margin, it's because their business model is tied to medical underwriting and medical share gain. So if they can upsell their pharmacy book of business up to medical, and they're making more money that way, and they can price lower than CVS, more power to them. An employer is going to pick them ultimately. CVS has had to tie it to the front store up until now, but the front store sales are getting eroded by Amazon. And over time, if Amazon comes into pharmacy, which we can talk about, that's going to put a hell of a lot of pressure on CVS. So I just think that, the employers need to go where the money is. I mean, why do they need complexity for no reason at all?
I could not agree more with what Anna just said about the Aon Hewitts and the rest of the benefit consultants out there, that they should look to themselves as to whether they're actually promoting efficiency or inefficiency, improvements in patient care, and the cost to treat them, because I would argue that there are times like now where they may be preventing it rather than enhancing it, and not therefore helping their self-insured customers' bottom line, whose goal overall should be having healthier employees who come to work with lower health care costs, as opposed to paying the margin of a middleman. And then, the one thing that I would just say is it's possible that Optum has not substantially underpriced, so a couple of pennies difference doesn't seem like substantial underpricing to me, but rather that because of their scale in other areas, especially in technology, that perhaps they just simply have a better, more modernized business model. So there are some aspects there where there may be a full competitive advantage, but be that as it may, sometimes the market, is actually smart in where it puts the stock prices, and CVS has had a rough time of it over the last couple of years, whereas United, multi-pronged as it is, has not, along with the other health plans who have not. So there's something cooking in pharmacy, and someone there, I think the bottom line here is someone's going to get squeezed, and you and I and everyone else in the room are hoping that it's not going to come, the funding for that's not going to come out of our pockets, but that whoever ends up winning is going to actually get us onto the right drugs at the right cost, as opposed to something that would be a less good outcome.
Yeah. If I could just say one thing in defense of the large benefit consultants, and we can argue all day about the model.
Why?
It's pretty hard to counsel employer purchasers on selection of vendors when you only have one or two, which is what we've gotten to with all of the consolidation.
And again, why do you need them? If my choice is A or B, I'm not capable of making that choice. Then why am I sitting there as the decision maker in a benefits consulting decision?
That's good. So, we were talking a lot about integration of medical benefits and pharmacy. Any other activities, tools that either PBMs or health plans are using to address rising specialty pharma spend?
It's Tier 4 formularies is one, because co-insurance on a very large price drug per patient it'll impact the choice. So that's one thing. I don't know that they're necessarily going to closed formularies or excluding coverage unless you have a substitutable option. That with Sovaldi, and I guess when AbbVie came in with their drug, They were considered, maybe there was the convenience element to the whole thing, but the companies managed to get amazing deals with Gilead on Sovaldi because there was an alternative, at least from from an efficacy perspective, even if they might have had to take the pill 3 times a day or whatever they had to do. So I think the formulary design and co-insurance is one. And then we can talk about, I guess, the oncology care model, which CMS has had in place and under the old administration, Obama administration, actually came out of an idea that Anthem had spawned to influence the choice of the treatment paradigm and the pathways, for oncologists. And what they did was they put a certain fixed dollar amount per patient, per cancer patient that was within a practice. And that was allowing the physician, the oncologists, make all their money on what they call buy and bill. Right? A lot of it is just being a distribution channel. But if they were given incentives to treat the patients in a way that made holistic clinical sense, rather than just do it to try to fill their bottom lines, if you will, that model then got adopted in the OCM, which I believe is still running even under the new administration.
I think so. Yeah.
Right, and I think they have 3,000 oncologists in that pilot, and it's a pretty large pilot, and they are trying to influence utilization in this case, by incentive alignment. Incentive alignment, the tier formularies are the patient, and the OCM type models are the physician, and that's how the payers are trying to steer patients to a certain therapy or not.
Good. Well, let's talk about in the insurer mergers now, and specifically, I was going to ask about actually I'd still ask briefly, the 2 years that the 4 insurers attempting to merge lost. Any sense of what they lost?
I mean, well, just to wait. I mean, look, one thing they lost was hundreds of millions of dollars that got spent on, not every penny of that was wasted, because there were some insights that came out of that, but very, very heavy spending on transaction costs. Sheryl.
So strategically, so it's good we're not saying the same thing. So strategically, I would say that they lost an awful lot of ground, and I think it's pretty clear now that you have the notion of Aetna perhaps merging with CVS, which will be our next topic, as perhaps a solution. One of the things that was an investment thesis while the 4 of them were figuring out if they would get along, get a divorce, if the DOJ would intervene or not to intervene, because it really made for a good sort of gossip column kind of reading every day if you like that sort of thing for healthcare. And it was sort of like, at some point, it just becomes too painful to see these deals done. But you do lose competitively, and so United was kind of sitting there as the alternative company who wasn't engaged in any of these transactions or distractions, that was able to invest according to its strategic plan, that was able to execute on that strategic plan, and thus gain ground versus the competition. During that period of time, you saw stunning growth, not only in Optum, but also in the United Healthcare health plan, because there was distraction, and there was, or at least we'll call it stability, because you were kind of sort of, if you were one of the targets, you were almost at a standstill. It was very hard to move ahead on a strategic plan, especially if the deal was not a friendly one. So, or excuse me, was a friendly one. Where it was not a friendly one, you'd probably try to do whatever you want to do anyway. But point being that now you've got, Anthem behind the 8 ball on its PBM, because the Express Script contract was seemingly unsatisfactory to them. And I'm sure Anna and Matt can comment more on that. And then you also have this whole notion of CVS and Aetna perhaps needing to get together to address what I think Anna was getting at, which is if you're a PBM like CVS, then if you don't have that health plan integration and aspect of it, you're really missing the boat on a large portion of the data and the synchronization and the risk that you need to manage, and the way in which you will gain market share by selling more, because the market's moving towards a more integrated product, or at least one that talks to each other. But where's the technology investment that's behind that, and how many years away is that, and how many more hundreds of millions of dollars will that cost? Whereas United already spent that money. So from a competitive perspective, that time that they lost dithering around on this, I think could be very damaging. And I'll just point out one other little thing that I found absolutely fascinating, and I don't know if it's meaningful, and maybe my colleagues here can help me. So when Anthem announced that they were going to go in and partner with CVS to build a PBM that was going to be their own, rather than give the contract to Optum Rx or CVS or leave it with Express Script or come up with some other solution, they called it Ingenio Rx, Ingenio Rx. So looking at that, I'm thinking, gee, that word sounds kind of familiar. What does it remind me of? Well, United's Optum Insight used to be called Ingenix. And Optum is called Optum Rx, which I tend to abbreviate ORX, as opposed to Optum Care, which is OC, and Optum Health, which is OH, and you get the drift, right? So we have Ingeni ORX. Ingenix RX. I mean, do you feel like, it's the sincerest form of flattery here? And I mean that seriously, because there's multiple years and millions upon millions of dollars that will need to be invested by 2020. And the irony is that United tends to be a seller when everyone else is a buyer. So by that time, 2020, you could already see the mail order and some of the fulfillment services being more than commoditized by who knows who, if it might start with an A, might not, and United will be a seller when everybody else is a buyer. That's been the historic pattern in PBM, because they sold the diversified pharmacy services long ago when everyone else was buying. So just an observation, they've lost a tremendous amount of time, competitive advantage, but it's a strategic advantage. It's a long-term advantage, and they may never catch up. So if you can't catch up, you'd better figure out how to leapfrog.
Yeah. Well, let's talk about the merger between Aetna and CVS that may happen. And the real question is not so much analyzing the companies, but in a sense reflecting on it is, what do you think they're trying to do? And what does that mean for the way healthcare delivery and financing is changing?
I think there's three big factors. We talked a little between the three of us of all of them, but the first one is that everyone wants to be an Optum. So it's this Optum wannabe thing that's going on, and Anthem is doing it with Ingenio, and CVS and Aetna need to do it with each other. So it's if you can't beat them, you got to join them and figure it out. That's one. Second thing is, as I said, CVS's front store sales have been really, really challenging, and this is even ex-Amazon
so the front
coming.
store sales,
front stores,
the
shampoo, and the greeting
care.
cards and all that. So that's been extremely challenging for them. That was the way that they were leveraging their pharmacy benefits manager model. And when CVS and Caremark merged, I don't know, in 2007 or something, 6 or 7, it was all the vertical integration was tied to bringing people to fill their scripts in the store and then shop, and now you have Amazon Prime, who's doing Amazon Prime same day in 2 hours, and they're going to give it to you, they're giving it to you, I think, with free shipping. So why would you go pay those kind of hefty prices for your shampoo and, anything else? So that's the other problem they're dealing with. And then the third one is the drug companies, I think, did a great job of pointing fingers at the middleman. And the retail pharmacy margins are in the high teens to 20%. How is that sustainable in a market where we're all saying that drug prices are just completely unaffordable for the American consumer? And the drug manufacturers said, gee, this is not about gross price increases, but it's net price increases of rebate. When you look at it, someone else is pocketing all of that. And the Hill and all of you paid attention. So no one is really going after the drug companies anymore. So here's CVS sitting, looking at all their customers, and now Anthem divorces Express. So what is that telling you? That your best customers are becoming your fiercest competitors. So it's not just that Anthem is, maybe imitating Optum, but what power does Express Scripts have? They were literally making, and they disclosed this in an SEC filing, like $11 a script or something. It was completely crazy, down to now. I would think, looking at the numbers that Anthem is projecting, which is $4 billion in savings starting 2020 when they switch, they're going to do $2 a script or less. I mean, all of a sudden, 80% of your margins are gone, and no one's shopping for shampoo in your store. What are you going to do, right? I mean, it's a perfect storm right now for these guys.
Do you think that Anthem will change its strategy terribly much once Gail sits in the seat?
Once Gail sits in the seat, we don't know what she's going to do.
There's a change in CEO. Joe Swedish is retiring. And Gail Boudreaux, who used to run the United Healthcare health plan and helped to turn it around in the post Bill McGuire days, is going. Her non-compete is over, and she's taking a CEO slot at Anthem.
I really respect Gail, so I'm excited. I think Anthem has certainly been slower at, and as stock analysts, we look at where is there, what's the next leg of growth, right? And so Optum is certainly on a tear, but Anthem looks like they have all the market share in the local markets. They've not been able to leverage their market share and their Blue Cross Blue Shield brand as well as they should have on a value-based care model, where control over your physician is your biggest, power. And so now I think they've kind of come out of some of the worst issues that they had under their previous CEO, not Swedish, Angela Brawley, and the 4 years of just challenging with Obamacare implementation and trying to fight Cigna legally in court and Express and all. Now they can kind of take the next move and build out Ingenio. She comes as CEO of United Healthcare, and so while she didn't build out Optum, she was in the C-suite as one of the 3 top leaders helping build out Optum, and so she can help drive that piece of it. And they've acknowledged that I think they wasted a lot of time with Cigna. If anyone has kind of said that openly, they've said that it was a mistake. It was, and it set them back. They don't think they're pursuing mega mergers anymore. They're doing roll-up consolidation on Medicare Advantage. So I'm not sure if she needs to change strategy. She can certainly help execution, which is not perfect right now at Anthem.
Yeah, well, let me talk about the Optum and the Ingenio and the possible combination of Aetna and CVS. It seems as though only the really large insurers can do this. And the question is, I know United historically, through the predecessors of Optum, always, had a business of servicing other insurers. And still do. Is that going to be, in a sense, what happens with the rest of the insurance industry?
I mean, it's certainly looking like that's where we're headed. And, the interesting dynamic there is that, you're correct that other plans, regional plans, smaller plans, have been comfortable buying services from Optum, even though Optum is part of, a very large competitor to them. But, these are services and units within Optum that are really at an arm's length or, very separate from United Health Group. The point I'm making, though, is that, as United bought Catamaran, a PBM, which served a lot of different health plans, I think that's been more of a test case and maybe a difficult one, because I've talked to a number of the smaller plans who've said they're not comfortable having their PBM business with one of their big competitors. But now, and that's being tested with Optum Rx, and I think the jury's out. And it may be that the jury has no place to go, because if Aetna and CVS are combining, and if Anthem's out there with a model that takes market share from Express Scripts, you don't have much left other than to compete with to contract with one of your largest competitors for PBM services. So that's something to watch. Just one other point on the Aetna CVS. It's still not been acknowledged by either company as something that they're actually pursuing, although it's something we've heard Aetna management talk about in investor meetings going back, not a merger per se, but what they might be able to do combining with a retail pharmacy company. We don't know yet, though, fully what the articulated vision is going to be here. And I'm not talking about the PBM so much as what Aetna and CVS together would propose to do with the 10,000 retail stores that CVS has. Of those retail stores, by the way, something like 1,500, I think, have
Minute clinics.
clinics. Not that that number is necessarily important for this, but is the vision there that Aetna would put a range of outpatient services into many of those stores and try to drive a revolution in where care is delivered to those sites being lower cost of care? That's something we're really interested in hearing from them if and when this thing goes forward. One other point to make on that, which is that Cigna has articulated somewhat of a different view, where they've said, we don't necessarily want to be tied into that kind of bricks and mortar approach, but because what we see as a technology is leapfrogging that to a lot of things being done at home with remote monitoring and so forth. Now maybe their view will change as this merger happens, but that's what they've said.
I mean, I guess, a couple of points on that. I think as Matt says, I think the Aetna CEO has been a little more open and vocal about the vision, and if the front store model is starting to get threatened, and with Amazon potentially getting into mail order pharmacy, maybe that gets even worse, then they can repurpose those stores into community health centers. That's kind of their real estate, let's leverage our real estate answer to Optum. And then you kind of build out something more around the minute clinic model, and you put telemedicine and behavior, maybe you can get some therapy and hearing aids, and they could wrap around a Medicare Advantage like offering, and that's kind of one way to go. It's going to be challenging to execute, and probably will take multiple years for something like that to materialize, because CVS still makes 25% of their retail sales from the front store, and they're lease stores, so they're responsible for those leases on their P&L. But that sounded like the kind of vision, I think, that that CVS, and CVS has never said anything openly, but Aetna has been painting with the company, like CVS, and then the rumors break, so it feels like that's where they want it to go.
Yeah, on the integration that we were talking about a few minutes ago, about with, in a sense, what Optum is doing with United, do Optum or Optum-like companies have the ability to actually accomplish some of the integration with their other insurer clients?
That's the goal, and in some cases they're able to, but obviously, there are going to be some not. They have an extremely flexible technology architecture that is designed to allow them to help me optimize the connectivity of their services to other payers and even to hospitals and that part of their business. So the answer is that's the goal.
Yeah.
One of the things that it's always a difficult choice. Why do hospitals choose to engage with Optum? Why do health plans choose to engage with Optum? So I think their answer is often, so if you have the largest scale and the lowest cost, you really want to go with someone else who's going to give you a cost disadvantage against you, who's going to bring a disadvantage to you on cost, rather than someone who brings an advantage. At the end of the day, it's going to be an economic decision, and it often is, so long as Optum can demonstrate that they're not sharing strategic data or initiatives with the guys on the other side of Eden Prairie, because the buildings are now at least separate.
Good. We've picked up some of this before, but as far as large employer benefit strategies, I'd always had a sense that some of the benefit buy-downs and other steps had been a response to the Cadillac tax, preparing for it. Cadillac tax is still on the books for 2020, but probably not expected to ever come into effect. Have you seen a difference as far as a backing off, or maybe a backing off just because, how much larger can you make the deductible without starting to sacrifice the reason you offered health insurance in the first place?
I think we haven't seen that yet. In fact, one of the things that has been surprising is the extent to which, at least from what we're hearing, that employers have been plowing ahead with, when I talked about the sort of cyclical taking your foot off the accelerator in terms of cost control mechanisms, employers have really not taken their foot off the accelerator in terms of particularly if you look at the penetration of high deductible health plans. Now, it doesn't look like that's changing for 2018 either. I will say the prospect of the Cadillac tax, when it was to go into effect in 2018, certainly was a helpful thing to point to for many benefit managers in large companies. They could say, look, this is coming. We need to get ahead of where this is going to put us by changing our benefits now. And there were specific examples of where that led to employers adopting consumer-directed health plans for the first time. And I haven't really heard this, but it wouldn't surprise me if that's still being used now that the Cadillac tax has been kicked out to 2020, but it's still on the books.
I think that, anecdotally, I have heard the pushback or less appetite for a higher deductible. I think there is some sympathy for the worker and the pressures that they face on out-of-pocket. And, you pay all of this in premiums, and unless you've been catastrophically ill, you hardly really get much benefit from what you're using, even if you get an ambulatory surgery procedure or whatever. But we still only have maybe about a third of the total, high deductibles in the classic sense. It's about a third penetrated, and maybe even less in, different depending upon the group sizes. So there's plenty of opportunity to increase the penetration rather than the deductible. Most employers will offer you a choice of a PPO plan versus a high deductible plan, and one has a slightly lower premium but more upfront deductibles. Then you have to make a choice, and they kind of are incenting the worker to make that choice. But there's a lot of headroom still to go.
Yeah. Is there any sign of, in a sense, when you think of it, if deductibles are too large to increase further, it seems as though the alternative way of still constraining your costs is to narrow the network.
Yes.
And I think large employers particularly had really not gone there for a long time. Do you see signs that that's changing?
Yeah.
They haven't stopped. I mean, they were not there at all 10 years ago, at all. And that was the biggest constraint for a managed care company, because on the one hand, they were being tasked with being the stewards of bending trend, but then the employers used to say, I want my worker to have access to Cedars-Sinai and UCLA and every expensive provider system in the metro area. And I mean, if your hands are tied like that, you can't really negotiate with that provider in any way. And I think you had some questions later on, or maybe it's part of the section around how come one of the factors as to, despite the hospital consolidation, we haven't seen pressure on contract rates for commercial contracts between health insurers and hospitals, is because narrow networks give them the flexibility to just kick somebody out of the network, and the employer is on their side, I think.
If I could just add, the real traction for narrow networks has been a lot more limited if you compare it to high deductible health plans. But let's remember how we got here. The other thing that happened in the last 15 plus years is that employers decided to move to models that were much more likely to be self-insured, much more likely to want to consolidate their business with one or maybe two or three carriers. And if you're going to do that, it's really hard to not have a big network, because you've got to take into account you've got a geographic and otherwise diverse workforce. But now the pendulum is maybe starting to swing the other direction. You hear of large employers doing what they call slice contracting, meaning that they're contracting instead of just one or two or three carriers. In local regions, they may be giving employees a choice of 5 different regional carriers that have narrow networks and therefore lower prices. And on the margin, there's also some of that's being done through private exchanges. So there is activity, but it's still on the margins.
So the one thing I would point to is that I would call it the narrowing of networks as opposed to truly a narrow network, although I think there are high-performing networks that are gaining traction with the most innovative and forward-thinking employers, which is not the entire group. But the employers certainly do provide a drag on all of this, a limiting factor on change. And that was when, as an example, United had this very embarrassing situation that despite being the parent company to Optum, United Health Group had some of the worst star scores of the big publicly traded companies. And when that happened, they discovered that they had to narrow the network. They had to really assess the physicians and the quality of care that was being delivered through those physicians and their ability to have a span of control that was appropriate over those physicians to encourage them to follow the proper protocols, close the gaps in care, make sure that the patient satisfaction and outcomes were high. When they started to kick doctors out of their networks, you know what doctors did?
They went to the government.
Sue.
Yes.
And they went to the government. They sued. So the pushback on narrowing networks is a real issue in some cases. It's a real problem. Ultimately, they were able to narrow the network a lot, and their outcomes and metrics certainly did improve. Maybe coincidentally, maybe not. But I would say that certainly on the Medicare Advantage side, they have had to do it because of the constraints they were facing on reimbursement and the need to increase star scores. On the commercial side, they are absolutely limited by what the self-insured employer will agree to, and that has been the case forever. And in some cases, some of the things that they were trying to do with financial incentives, that if you act in a more a healthier way, if you do your numbers and you get your diabetic numbers down, or you become a non-smoker, they would provide a premium incentive for the good behavior. So a different way of getting cost trend down was by paying people to do smarter things for their health. And some states that's illegal, you can't do it. So there's a lot of complicating factors. Narrowing the network addresses a lot of that because you'll end up with a better protocol that when physicians who get better engagement with their patients to get them to healthier status.
It seems what United was doing to narrow its Medicare Advantage network was far more challenging, because they were basically booting people out who were willing to take the rates they offered.
Yeah, it wasn't about rates. That's
Whereas,
exactly right.
in a sense, if you're going to take a very expensive hospital out of a network, that's a very different story.
Well, I think, but the whole concept of narrow networks, you bring up a great point, Paul. It's less about rate and more about quality and outcome that defines a premier provider. Rate's important, but a premier provider. And then there was one other point. I once asked someone in managed care, why do you still pay hospitals such high rates and 5 or 6% price increases every year? And the answer is because without us, they'd go under, and we still need them.
Yeah, actually, I was going to ask about the degree to which narrowing of network is taking into account outcomes quality as opposed to being strictly a price thing. I don't know if anyone
I
has
can
an
only
answer to that.
speculate here, but I think narrowing a network is turning into a more strategic partnership between the payer and the provider. So whether or not there is an outcomes metric that's being attached to it, at least it helps the provider cares much more about the processes and disease management and care coordination approaches and quality star ratings and all of that, and the objectives of the payer, because they're seeing far more patients coming through their doors that are attached to that particular payer. And so I would speculate that it'll drive a more outcomes focused care delivery from the provider, as opposed to a much more transactional relationship that you might have with multiple payers when there isn't a narrowing of the networks. And the payers, when they're taking on a strategic partnership with the provider, they look at risk, whether it's a large physician group or a health system, they're looking at risk readiness. How ready is this provider to be part of a strategic relationship that I have? And they use different algorithms to do that. Optum talks about this in some of their more flagship strategic relationships are like Northwell and Dignity and so on. But there are many startups that just specialize in software that helps a payer determine, do I want to invest in this particular provider system as part of my narrow network? Invest perhaps not just in teaching them and giving them access to my programs and capabilities and systems, but in some cases they also offer them balance sheet strength to help them invest in what they need to do to become risk ready and become a preferred supplier to you.
That's very, very interesting. Actually, speaking of Northwell, I gather that they shut down their plan.
They did, after writing a big check to a large publicly traded managed care company for their risk adjuster payments.
Mhm.
Close to 90 million, I
Yeah,
believe.
and the question is, do you see in our future, any significant degree of, health plans owned by health systems, or even the branded model where it's a partnership with an insurer with their brands, or is this kind of something that'll pass?
I mean, I think that it's understandable why Northwell and some of the other provider-sponsored plan attempts have run into trouble. I mean, the biggest reason, and Sheryl alluded to, is because of their natural focus was on the quote-unquote opportunity in the health insurance exchanges, and that turned out to be a terrible first place to do business as a health plan. At least thus far. But the one thing that I think we know can lower healthcare costs materially, while improving quality is well integrated care, and that's what provider-sponsored plans potentially offer, whether it's done on their own or whether it's done in partnership with the payer. Is pulling together an integrated care network and providing the outcome at a lower cost. But you need to have a purchasing structure that works with that model, meaning that these integrated care systems are out of necessity narrow networks, and therefore you really need to have retail individual selection of health plans, rather than the sort of typical employer group model. And in fact, there's a little bit of a chicken and egg dilemma here, which is that, in some ways, the integrated provider plans, or at least network offerings, aren't going to be there until you have the critical mass of retail purchasers. But we're not going to go to a retail purchasing type environment until employers can see that there are demonstrable cost savings, which doesn't happen until you have the lower cost integrated plan offerings.
And in Medicare Advantage, which is the other payer mix that provider-owned plans have had to tried to pursue, there is also a huge scale advantage, not just in the care coordination approaches and systems and processes, but I think it's underestimated as well, and Kaiser says this, what the health plans need to do to sell the plans. It's around distribution and advertising and all of that. So for a smaller regional health system to come in and brand themselves and develop the relationships with the brokers and pay those kinds of commissions becomes very challenging, and it's an underappreciated skill set. And maybe you have sometimes the Medicare Advantage plans who contract with primary care docs. The docs say, but gee, I do everything. I'm dealing with all the patient care and all of that. What are they doing? Well, they're firstly selling the plan. That's how you got the money to begin with, and then they're helping to scale it up through systems and processes. And then there's balance sheet capacity, right? It's 10 to 15% of your premiums have to be ring-fenced in a balance sheet against the provider claims that will have to be paid out. And if a hospital system is running at high debt ratios and their whole business model is tied to weak cash flow generation and capex and all, there's just a conflict here. So a little bit of shared risk, yeah. Provider-owned plans, I just don't think they will.
Yeah. Can I just make
Sure.
the whole concept very simple? The goal and exercise of any of these shared risk entities and any of these health plans is going to be to reduce heads in hospital beds. Whether it's going to be the acute bed or the post-acute bed, that's what they're going to do. That's where their first and most obvious, lowest hanging fruit is. So what hospital has the ability to get such shared savings and such a large share of shared savings from the population that they will insure through their provider partnership to take risk? Very few of them. Very few of them. Because the negative impact of losing heads in the beds cannot, at least in the early stages, be more than offset by their percentage of the profit that they just gave up. Right? Take 100, divide it in half. You still have 50 cents on a dollar. So that's one of the reasons why these hospital provider or hospital physician plans and hospital health plans tend to have an inherent conflict. I think if you go all the way back, it may be one of the reasons why Humana ultimately split off from its hospitals.
You know, Sheryl, that's a good point. I would say that it's one reason why some of the large physician groups in California would argue, you know, you can't have hospitals running these plans, and they shouldn't be at the center of the ecosystem.
They exist to fill beds.
And the evidence from integrated care systems in California, at least some of it, is, you know, would perhaps back that up. The problem in many areas of the country, of course, is that hospitals are the only units on the provider side that are, you know, that have scale, that have organization, that have capital to pull those things together.
Unless it's a health plan physician.
Right.
Yeah. Good. Let me ask you some questions about alternative payment models, you know, ACOs, bundled payments, and just tell us about the perspectives that both private insurers have, providers have, on the potential in these arrangements and the degree to which they're putting capital into expanding them.
Can I just say ditto on the hospital side? So you don't want to put money into an ACO whose sole goal is to empty the patients out of your bed if you're a hospital. So it's a fundamental conflict of interest, and it's a serious one. It doesn't stop them from doing it and attempting it, because that's sort of they're asked to do it, and it's the model, and they want to try it, and maybe they can make it work. But it's one of the reasons why you do not see the proliferation of hospital-based ACOs. You do see the proliferation of physician-provider health plan ACOs.
Yes.
Those are growing very rapidly, and they are generating meaningful savings.
I don't have the numbers, but I think, you know, I mean, there are quite a few hospital-centered ACOs, and I don't disagree with Sheryl with your take on that.
All of the Medicare ones have to be, because the health plans were excluded.
Right. You know, but the separate point I wanted to make is the hospitals may very well you know, only want to take it so far, because they you know, they have this conflict of interest as it relates to you know, bed day utilization. But the ACO is also a partially safe harbor for consolidation within their local market, and you know, that's often the first thing that happens, and regardless of where we go from there, that can be beneficial to the hospital system.
Yeah, I think it's going to be the primary care. I think is the easiest access to see so-called alternate payment models, because there's incentive alignment across the payer and the provider. It's easiest for Medicare, you know, then maybe Medicaid. The adoption has been less for commercial because the payout is not as easy, because it's not that quick to just say, I'm going to cut, you know, X number of hospital admissions and readmissions with more care coordination and save you more money, and let's split the, you know, the difference. But I feel like it's not just going to stop at these contracting relationships. I mean, Optum has been going at it methodically in all of the markets that they're targeting and buying these docs. And for a while, it was Humana who, you know, started some of this, maybe in 2011, 2012 or so, under the old CEO, Mike McAllister. But it feels like they're resuming the purchase behavior as well. Again, I felt that for the first time this time after that third quarter, that they're back in the Carolinas on the prowl and buying. So it's an arms race for primary care physicians across all of the plans. Still to some degree, and you know, both of you should opine, but I feel like it's slowing down on physician employment on the hospital side, but it's not dead yet by any means, and maybe macro and these other things, you know, drive that to some degree, again, accelerate it. And then home health assets, I think, are, everyone says they want to buy a home health company. I mean, none of them have been sold yet, but there's not that many to begin with.
But
So.
when you say everybody, who are the buyers of home health companies?
So
Health
United
plans.
says that it's a huge priority. Humana says
Okay.
it's the absolute top priority. CVS is saying they want to buy home health, and I mean, if everyone wants
There's
to buy
only
home
a
health,
handful of publicly traded
like what?
companies, and there are still some private, because I cover the home health companies, and, you know, gee, I hope they keep their word, because that's the thesis in part, but, you know, home health isn't the easiest, nor is it the most efficient model in the world. So a couple of thoughts here. First of all, on if you think to tie this into premier networks, so if you think about what Optum Care has said that they are doing, and I do see them doing this, they are looking for a very specific kind of physician practice, one that is adaptable to the analytics-informed, technology-driven practice of delivery of best practice patient-centered care. Put every buzzword in it, value-based, everything, okay? Just load it up with buzzwords. That's what they're going for. But behind the buzzwords is there isn't a system out there that is either linked to a payer or not linked to a payer that can routinely and consistently, in a very patient-focused way, deliver the right outcome at the right cost. So if it doesn't exist and you got scale and money and brains, you're going to build it. And that's Optum Care in a nutshell. It's not a mystery. It's as narrow and prestigious a network as you will ever see. And if they're right, and if they can get to where they want to get to, because who starts the process of paying for health care? The primary care physician and his or her pad and pen, okay? So you've got to own that. Now, as far as hospitals are concerned, as usual, hospitals have difficulties making money with doctor ownership, practice ownership. And now it's become very clear that, you know, I think we all were kind of aware of what they were doing. When it was a freestanding doc practice and it could bill under Part B, it got this much. And it became a hospital-based outpatient service, and all of a sudden you repriced it and you got this much. And that game is pretty much called. I mean, it's become visible, daylight's in on the magic. I think that margin goes away. Whether it's immediate or whether it takes a little longer, it's done in steps or not, that's done. So the whole incentive of being able to reprice, remember like specialty pharma companies did, they bought old drugs and they repriced? It's the same sort of thing applied to hospital. The ability to reprice, that loophole, I think, is basically going to be done. Now, managed care has pushed back on that in the past. There was, I can remember when Texas Health Resources, I believe it was, bought a physician practice in a part of the state where they didn't have a whole lot of oomph, and they didn't have a whole lot of market share. The Blue Cross plan, basically, that was covering the Texas state employees at the time, said there is no way we're repricing those doctor practices. Absolutely not. And you had these two big behemoths fighting it out, and guess what? The doctor practice didn't get repriced. So there's some precedent here for the health plan actually having some leverage not to reprice these services. If you can't reprice them, I don't think there's an opportunity for the hospitals to make an adequate return to continue to buy them, other than it's very well established in the data that if you own the practice as a hospital, the primary care and the referral sources will refer more of their patients to the hospital who owns them than they will to any other hospital in the market.
Yeah, so it sounds though there's still potential for the hospital of employing physicians, but it's lower because the repricing is going away.
Yeah.
So they still can get the referrals. Of course, this means they have to be able to actually effectively manage the practices.
And they're frequently not able to do that so well.
And there's a defensive element of it
That's
too,
right.
which is to the
Prevent
extent
someone
you
else
have
from getting
Optum
it.
and others buying up physician practices in your market, you want to own some too.
Yeah. Good. This would be a time to go for some questions in the audience. And but otherwise, yeah, okay.
Jan Heinrich. Many states have been working on innovations and alternative payment models, and so you have places like Maryland that have global budgets, and that's now expanded to Vermont, and there's a new alternative payment model in Pennsylvania that's focused on small rural hospitals and critical access hospitals moving to global budgets. Can you say something about what you're seeing in those markets? Because we all know Baltimore is a terribly competitive market, but they seem to like it.
Who seems to like it? I'm sorry, I missed that.
Hospitals.
Hospitals seem to like. Well, again, that's more of a not-for-profit market. So I can't really speak to why the not-for-profits like Baltimore. But if the last I heard, isn't it Maryland a Medicaid expansion state? So if you take away the expensive lower rung of uninsured and you give the hospitals a financial cushion, from that point forward, you now have a much better platform to run on. I do know that the home health business in Baltimore is growing by leaps and bounds. And the one home health company that I cover that has business there can't hire what they call business development team fast enough to be able to capture all of the referrals that are there. So I have to wonder whether there's not something in the demographic that's flipping that to be a demand growth market, and that may be supporting the business.
What payer mix are we talking about? Is it like, what is it, long-term care? Is it age-blind disabled? Or when you say states are doing these global payment models, considering most of,
This is for acute.
It's acute care. Yeah.
oh, this is on the hospital, but I mean, is the state doing it as a payer, or I'm not quite
no,
clear?
as a regulator.
Oh, as a regulator, okay,
Yeah.
got it.
Actually, when you mentioned about the growth and demand for home health, this is probably all part of the attempt to rationalize care.
Absolutely.
And especially in the elderly population, a lot of Medicare Advantage activity, some of the alternative payment models, that's where the savings are for hospitals. Yes, they're going to lose some heads and beds, but to the degree that they can get the patients, much more efficiently use the post-acute care, don't put them in nursing facilities, use them home care. So in a sense, it's probably a healthy thing that it's growing so fast. Yeah, Deb? And then,
Thanks, Paul. But isn't it also true that if you don't control the home health and you get a referral, and it's a very expensive referral, like under Medicare rules, let's say they would pay that, then that can kibosh any of your savings? So if I were a plan or somebody else like that, of course I'd want to do home health so I could keep the heads out of the beds, but not get the right balance of referrals. Let's just put it that way.
So yes, I mean you want to make sure that there's not unnecessary utilization at any part of the spectrum of services, and there is a view about home health that with the kind of error rates in billing that they have, that every single one of them commits fraud. So it's probably not the case that it's 100% fraudulent, but we certainly do have a generally very hard to supervise, very hard to limit benefit because it's being done in the privacy of the home. But having said that, you're still, if the average Medicare revenue per episode for the publicly traded companies of reasonable intensity of service is about $2,800 a month.
It's also linked
an
to
episode.
bundling, right? I mean, bundling is the
Well,
other
bundling
reason
is
they
the
would
thing
do
that's
it.
driving a lot of
Home
that,
health
and I
as
get
well,
that. But
yeah.
if you're talking about the average Medicare, it's not actually driving that much volume growth. You'd be surprised, and that's a problem. It's not driving it, and it's $2,820 per episode on average for Medicare. Okay, so you're going to spend $2,820, but you're going to save $10,000 or $15,000 on a subacute, so you're still ahead of the game. You want to talk about the other part of that?
excuse me?
No, go ahead. We can move on.
Oh, I was just going to move on to the
Yeah.
next question.
I'd like to ask you to speculate a little bit. If this administration is successful in essentially overriding state insurance rules by allowing plans to be sold across state lines, and we have been talking about competition and the impact, what do you see as potentially the impact on any trends that we're seeing as one question that I have?
I mean,
Yeah,
I'll
go
just
for it.
sure. I'll just offer. I mean, you essentially, you're essentially stripping away the state level regulations on small insurers in particular, because they're not small insurers. I meant small group, because they're more heavily regulated. And you get presumably where the insurers are domiciled for these multi-state plans is going to be in whatever jurisdiction has the least regulation. So there'll be sort of a race to the bottom. And one result you might expect to see from that is some bifurcation of, and I'm sort of thinking that association health plans go along with this, but some bifurcation of underwriting risk in the small group going back to a more medically underwritten model.
Sure. Bruce?
No worries, at least we cleared a path.
Did somebody say, hey, Siri?
Hi, I'm Bruce Steinwald. I'm a member of the physician-focused payment model technical advisory committee. It took me 6 months to learn to say that. That was created in MACRA to review and recommend proposals for alternative payment models, especially those that are developed by physician organizations. And if our focus is on Medicare, but I wonder if you are seeing models like that developed in the private sector. Certainly you're seeing some cancer models, but other specialties and conditions are developing models as well. And I'm wondering if you think if you're seeing it, and do they have much potential, do you think, to reform care and where care is delivered and how much it costs?
So I'll take a stab at that. So I'm definitely seeing it, and as you suggest, mostly in the cancer models, because that's the easiest place to, one, identify and a difficulty or a challenge, shall we say, a problem with the existing incentives under the old model that, as some were, infamously quoted as saying you're paying doctors to be, drug pushers instead of being physicians when you tie their reimbursement to how high a price drug they prescribe. So let's change that, and let's think about what outcomes we want, so you change that. So we've seen that. Where we've also begun to see some alternative payment models is where, especially on the gerontologist side, under sort of the Medicare Advantage, where the inclusion of, for example, hospice into the decision making can lead to a much lower cost with kind of improvement in quality of life, especially at the end stages of life. So I don't know that you call that an alternative payment model so much as it results in some cases I've seen where in these limited studies that the doctor choosing to make that choice even 2 or 3 weeks earlier when the patient is terminal can have a dramatic impact on cost. And if you give the doctor some structure that rewards them for quality of life, not necessarily for cost savings, but quality of life, that you can achieve that outcome. So I've seen that be implemented in limited ways in a couple of practices. But by and large, when I'm not seeing the health plans talk about, certainly not very loudly or much out loud, how they're changing the physician payment models. Now, part of that's going to be competitive, and the other part of it is that every time you change how you pay doctors, they tend to yell and scream a lot. So you think you do your research and your modeling very intensively before you then select a group of forward-thinking or interested physicians to pilot this with, and then you announce it when the pilot is done. So these pilots may be going on and we don't know it.
Good. This is a good time for us to end the conference because our time is up. We could have gone on for another few hours otherwise. I want to thank the panelists for the extraordinary job they did. Also like to thank the JKTG Foundation for its funding of the event, and Alwyn Castle and the JKTG staff for all they did to put this event on in a very seamless way. Thank you.